Hi everyone, and welcome to the 14th TIA Centre Seminar of the academic year. So my name's Adam Shepherd, and I'm a researcher within the Tissue Image Analytics Centre here at Warwick, and I'm also joined by my co-host, Jachi. And for those of you that are new to our seminars, we invite researchers and leaders in the area of computational pathology and associated areas to discuss their work. And today, it's a real pleasure to introduce Dr. Duan Zhiyun. Duan is a medical doctor at the Zhongshan Hospital of Fudan University in Shanghai, China, and is published as first author in several great journals in medicine, including Cell Reports Medicine, Nature Cancer, and the Journal of Translational Medicine over the past few years. And the title of the talk today is Foundational Models in Oncology and Why Benchmark Success Does Not Translate to Clinical Practice. So, Duan, thanks again for joining us, and it's with that, I'll pass over to you.
Yes, it's a great honor to be here. So I can start?
Yes, please.
Yeah, okay. Good afternoon, everyone. So it's a great honor to have the opportunity to join today's seminar. My name is Duan Zhiyun from Fudan University, Zhongshan Hospital in Shanghai. Today, I will be sharing our perspectives on foundation models in oncology, specifically focusing on a central question where these models, when benchmarked, why do they often miss the clinic? So in the past 2 years, foundation models have made remarkable progress in oncology, trained on increasingly large and diverse datasets. These models now show unprecedented capabilities across genomics, spatial biology, digital pathology, and clinical techs. A striking example is ProV-GigaPath, which was pre-trained on 1.3 billion pathology tiles. Importantly, this scale translated into strong benchmark performance. ProV-GigaPath achieved state-of-the-art results in 25 of 26 benchmark tasks. Beyond these, models such as single-cell GPT, Conch, Shift, Amy, and Onco large language models are also rapidly reshaping the oncology AI landscape. However, despite these impressive achievements, a central paradox remains that foundation models are winning benchmarks, but their translation into real-world oncology is still limited. Most benchmarks currently evaluate well-defined and static tasks, while oncology practice is dynamic, multimodal, longitudinal, and deeply patient-centered. A patient's journey is not a single pathology slide or CT scan, but a continuously evolving narrative. This gap defines the central challenge for the next generation of oncology foundation models development. Here we outline several fundamental challenges that we think it must be overcome to bridge this gap. So the first challenge is multimodal integration. In current clinical oncology, diagnosis relies on a variety of data types. Pathology styles, tablet assessments. Histopathology remains the gold standard for definite confirmation. However, while recent foundation models achieve impressive results in individual modality, there are even ongoing efforts to develop multimodal fusion models. Yet truly integrating this data to match the complexity of clinical workflows is still in its infancy. In other words, current models are strong specialists but naive generalists. And we think there are two major barriers limit multimodal integration. First is data heterogeneity. Pathology slides, radiology image scans, genomic profiles, and clinical texts differ in format, scale, and quality. with additional variability across scanners, protocols, and language. Second is high quality, fully annotated multimodal datasets are extremely scarce nowadays. Without comprehensive data, models struggle to learn crucial intermodal relationships and the inconsistent expert annotation further undermine models' reliability. Together, these challenges prevent foundation models from fully integrating diverse clinical information. And the second challenge is from snapshots to timelines. As we all know, cancer is an inherently temporal disease, involving over months and years through tumor biology, immune response, patient-specific factors, and the treatment intervention. Most datasets used to train foundation models are just cross-sectional snapshots, which obscure the full disease trajectory and create a missing context problem. Models trained this way may perform well on benchmark tasks, yet fail to generalize in real-world oncology practice. Bridging this gap requires longitudinal datasets that integrate image, pathology, genomics, and clinical follow-up, enabling models to learn from the irregular and diverse trajectories that reflect real patient journeys. The third challenge is to capture clinical reasoning. Most current biomedical datasets are annotated with simple labels such as malignant or benign, but this entirely omits the underlying reasoning process. Clinical judgment is deliberative, weighing evidence, balancing risks, and integrating patient-specific factors. Models trained solely on outcome labels can only mimic decision without understanding the rationale, leading to brittle behavior, low interpretability, and limited trust. And to address these limitations of labels-only datasets, we need deeper rationale avoid annotations, capturing not just what decision was made, but why. Multidisciplinary tumor board proceedings are ideal source, we believe. As specialists collaboratively review patient history, debate competing evidence, acknowledge uncertainties, and reach a final consensus. Learning from this rich deliberative process allows models to move beyond accurate outcomes, producing decisions that are transparent, trustworthy, and aligned with real-world oncology. And the fourth and the last challenge is patient involvement. Despite unprecedented achievement and progress, current foundation models mainly serve researchers and clinicians, optimizing predictive accuracy and other things like biomarker discovery, while largely ignoring patient experience, preferences, and the quality of life outcomes. Domains such as subtle monitoring, toxicity prediction, psychosocial support, and shared decision-making remain largely underexplored. Patient involvement through advisory boards, surveys, and core design workshops can guide research priorities, define meaningful outcomes, and ensure AI outputs reflect lived realities. Incorporating equity and patient satisfaction alongside technical metrics produces transparent, reliable, and user-friendly AI tools that better serve patients. So in general, foundation models have enormous potential. We cannot doubt that, but translating that into clinical practice requires more than better engineering. They must evolve from narrow specialists into trusted generalists capable of integrating diverse data, following disease trajectories, supporting transparent reasoning, and incorporating patient perspectives. This is fundamentally an educational challenge. Physicians, data scientists, and patients must curate multimodal, longitudinal, and rationale-rich datasets as a model's curriculum. Only then can models learn how to think, not just what to predict, and mature into trusted clinical partners, advancing cancer care. So we believe the future of oncology AI development, foundation models development, depends not just on building bigger models, large-scale datasets, but on becoming better teachers, enabling models to truly learn how to think. That's all I shared today. Not so much, but I think it is quite important since we are in an era of AI for health. And thank you so much. Pretty open for the discussions.
Amazing. Thanks, Joanne. Thank you very much for that really interesting talk. So yeah, let's open the thought to the up to questions. Does anyone online or in person have any questions they'd like to ask Joanne?
I
No,
I
Joanne, I
can
was just
point
asking
someone
people.
to ask a question.
Sorry, Joanne. No, I was just asking if anyone online or in person had any questions to ask each other. So I suppose the first question then. So of course you've sort of labelled these four key barriers. So have you got any sort of solutions towards well, have you got any can you pose any potential solutions for sort of making these models more patient centric?
You mean the first challenging, the patient involvement?
Yeah, so I mean, so you've sort of mostly described these four major challenges that we have. I was just wondering if you could potentially discuss some of the potential future directions or avenues that we can do to solve some of these challenges, so to get more patients involved in our studies in terms of throughout the whole cycle, really, whole research cycle.
Yeah, actually, we are working on this project actually. In I guess in lung cancer field, we try to initiate a prospective study and incorporate the AI models, large language models, into our clinical practice, into the whole trajectory of a lung cancer patients, including diagnosis, treatment, follow-up, and recurrence and further treatment. So there are multiple encounters between AI, physician, and the patients. So we can evaluate the AI performance at multiple time points. And there are multi-interactive interaction between different multi-stakeholders. So we believe
Sure.
this can help to truly benchmark the clinical readiness of the large language models or other foundation models.
And what sort of, I suppose, what sort of feedback are you actually getting from patients at the different stages of the model development? I don't know if we've lost you there, Joanne.
Sorry, you are frozen again.
Oh dear. Can you hear us okay now?
Yeah, it is okay now.
Okay, no, brilliant. So it was just about, so you were saying in terms of getting patients involved at each sort of stage within the actual research pipeline. But what sort of feedback do you mean by that at each individual stage?
What feedback you mean? You mean
So so normally when we sort of get patients involved in terms of getting feedback, it's normally when we've sort of finished the study or so I just wondered how you were embedding this throughout.
You mean patient feedback?
Yeah, exactly.
Oh, yeah. So we set some metrics about the patient feedbacks, like the empathy, like the accuracy, what do you think of the model's output? Can you benefit from the model's output? And also, we even let the patients join in the project design. They work with the physicians and the data scientists to design the project. So what kind of metrics we need to evaluate, and at what point we need to, I guess, to draw to to get the output, and yes, so we just take the patient into the project, not a, a separate separate part from the whole things.
Sure. Okay. No, thank you very much, Joanne. So do you have any more questions from anyone in the room or online?
Hi, I'm Yupei Zhang. May I have a question? Can you hear me?
Yes.
Yeah, I'm a second year PhD student now at the Cambridge. So I really appreciate the talks integrating to different modalities of the patient and building the dynamic data from different time point. I think it's really important to represent the patient level representations from all kinds of data and time point. Um, but my question is, how do you think the cost for collecting such big scale data? I mean, it must it's a collaboration from different departments, different doctors, and also technical staff. So, uh, how do you think how do we like quality the data needed for this training? So
Yes.
how do we like quality what kind of data is enough or when should we start or it's a dynamic thing so we can add more data in the future, add more and more.
Yeah, I think your first problem is about the cost. It's about the financial burden.
Yeah, it's one aspect.
Uh, yeah, so first, in China, we have many patients, I guess you know it. And that means we have many data from these patients. And also, the government now is largely support the AI for health, especially for application, not for development. We need to deployment the AI in the healthcare systems. So we have many 这个 financial support. So
That's not a problem
that's
in your project, right?
yeah. But I think what I can say is there are many, I guess, students work with no salary to to support this project to get the project going well.
Yeah, I
And
mean, if from a,
financial
yeah.
always a problem. Financial burden always a problem. But I believe when we use these models in the future, in the near future, it will reduce the cost. I guess unbelievable. It will reduce unbelievable costs. especially when we have large patients wait for us to treat, to deal. And the second is the quality of data.
Yeah, how do we?
So that means we need to cooperate it tightly with physicians, with clinicians.
Yeah.
So in many current projects about AI development is initiated and managed by data scientists or other scientists, but they don't know what kind of data we actually need in the clinical practice. So I think we need a, multimodal team to initiate the project and to do this project and to design what kind of data we need, also interact with the patients and then let them to tell us what kind of data they want to, what kind of model they want to predict. I'm not sure what it is. I answer your questions.
Yeah, totally. Thank you so much for these two small questions. Thank you.
You're welcome.
Brilliant. So I also have another question about, I think the third challenge, I think you said about capturing clinical reasoning. I just wanted to know what your thoughts were around in terms of sort of newer agentic approaches that may be able to sort of weigh evidence and sort of incorporate clinical reasoning through sort of medical documentation which they can retrieve from. Is that the sort of future directions you're anticipating to solve?
Yes. Nowadays, many datasets are just consist of single labels like malignant or benign. But I think the most important thing to teach models is how to think, not how to predict. And while trying to establish some comprehensive datasets, including the experts annotation, including expert clinicians annotation into the clinical practice, into the disease progression. So for now, it's just a text-based. Maybe in the future, we try to get it multimodal. And also, I heard a theory maybe on a conference, in a conference. So a person told me that we have, I guess, the infinitive data to train. Infinitive or uninfinitive, infinitive data to train. But with the annotation, with the reasoning annotation, we have uninfinitive. So I guess this is the future direction.
Sure.
Infinite. We have limited information to limited data to train the models. Similarly, we already reached the threshold of the scale of the data sets. It's billions. But we have infinite annotation data sets to improve these models.
Okay. Sure. Brilliant. Thank you very much, Duan. So I suppose we haven't got any more questions from anyone in the room or online. I suppose we'll draw the seminar to a close. But thank you very much, Duan, for a really interesting talk and for giving up your time to speak to us. And thanks also for everyone. Yeah, thank you. And thanks everyone also for that's joined the meeting online and in person. So our next seminar is scheduled for Monday, the 11th of May. And we have a talk by Dr. Mark Schublik from UC Utrecht. So hope to see you all there. But for now, thanks again, Joanne, and goodbye all.